So here we're going to go through a primer on the meninges and cerebrospinal fluid of neuroanatomy. We'll talk about the essentials of these structures. We'll talk about herniations and hemorrhages, and then we'll talk about spinal meninges and how they differ from the cranial meninges. So this is our overview tutorial of the cranium, its meninges and CSF. These are the layers and spaces that we'll walk through in a second, but before we do, just wanted to point out when we're talking about the dura mater, this is what we are actually visualizing, this thick outer covering of the brain. We talk about the arachnoid mater and the pia mater. The pia mater is the parenchyma, the surface of the organ itself, and then the arachnoid mater is this translucent filmy substance that we can visualize here. So let's walk through these individual layers and spaces now. So first, outermost is the dura mater. That was that thick covering. We show it here in our pictorial in green. Underlying it, we have the arachnoid mater. We show it here in blue. And then underlying that is the pia mater, which would just be the surface of the brain here. Now, when it comes to the spaces, there's an epidural space just outside of the dura. It's a potential space, meaning it doesn't naturally exist, but it can be created through injury, such as we'll see with epidural hematoma. And then there's a subdural space, which lies beneath the dura, between it and the arachnoid mater. And again, it's a potential space, as we'll see with subdural hematoma. And then there's the subarachnoid space here we see in blue. Now this is an actual space filled with cerebrospinal fluid present all the time. When it comes to the spinal meninges, the epidural space is an actual space. We see that here. So here we don't see any natural space, here we do. That's very important for pathophysiology because it means that various processes, such as infectious processes, can invade this epidural space and make a home here and create a lot of problems. So these are various hemorrhages. This is epidural hematoma. So there's this biconvex lens shape here, and this space has been created when the blood fills here. Then here's subdural hematoma. This forms this crescent shape layering across the brain here. Again, it's formed in this case when bridging veins are torn. In this case, the epidural hematoma, the most common, is middle meningeal artery rupture. And then subarachnoid hemorrhage, we can see here all this white around the brainstem region and this star-shaped blood filling that region. So herniations and hemorrhages. There's some key characteristic findings of various hemorrhages that you need to be well aware of. So these are the intracranial hemorrhages we'll go through. We've already talked about 3 of these. There's also intraparenchymal hematoma, meaning blood within the tissue itself, within the brain itself. And then these are various herniation syndromes. We see subfalcine herniation quite commonly clinically. Uncal herniation we see clinically as a warning sign of brain further herniation, and then downward total herniation of the brain can be life-threatening. So this is the brain cavity here. So there's supratentorial, meaning that everything above the tentorium, and then there's infratentorial structures, meaning below the tentorium. So infratentorial then would be the brainstem and the cerebellum, whereas the cerebral lobes would be supratentorial. So these are the various hemorrhages. We talked about epidural hematoma. We show it right here. It has this biconvex lens shaped, and it's blocked by the cranial sutures. So the sutures create this pattern. Middle meningeal artery rupture causes this high pressure system to form. In converse, the subdural hematoma, bridging veins shear, this low pressure system forms, and the blood layers out along the surface of the brain. It's blocked by dural reflections. They form its shape, and it forms a crescent shape. So the typical clinical scenario in subdural hematoma is an elderly person. They've had atrophy of the brain, meaning there's more space available. They have these friable bridging veins. They have a sudden fall or a jerk type motion, a whiplash type injury. that tears these bridging veins and causes this blood to pool. And then subarachnoid hemorrhage. We saw previously that star-shaped basilar cistern hemorrhage there, and we show subarachnoid hemorrhage. And here, we always think about arterial aneurysm if there isn't a trauma as a potential cause of subarachnoid hemorrhage. Finally, intraparenchymal hemorrhage or hematoma, most commonly related to hypertension, most commonly in this basal ganglia region. Also, another common location is in the cerebral lobes themselves. When it comes to herniations, we mentioned subfalcine herniation. So any degree of significant pressure on one side of the brain is going to cause the brain to herniate underneath the falx cerebri and towards the other side. And then we talked about downward central herniation. And then uncal herniation. This is incredibly important. So we're going to walk through some key clinical pathological findings in uncal herniation. So this is the uncus of the temporal lobe here, and then this is the midbrain adjacent to it, and then this is the tentorium. So in uncal herniation, the medial temporal lobe, the uncus, herniates over the tentorium and can compress the brainstem. When it does, a telltale sign is compression of the third nerve, so the eye is no longer able to constrict appropriately and it dilates. So a dilated pupil is a good warning sign or an important potential warning sign of uncal herniation. In addition, there are motor fibers that can be compressed. When they're compressed, the opposite side of the body is weak. So this is a typical classic uncal herniation. There's also something called Kernahan's notch, which is formed and creates what are called false localizing signs. The reason that they're falsely localizing is because there's compression on the side of the brainstem opposite where the herniation exists, meaning the third nerve in the other eye, and the opposite side, is unable to constrict and is dilated. And then because there's compression of the opposite motor fibers, the ipsilateral side of the body is weak to the side of the herniation itself. Spinal meninges. Just an important clinical note. Typical lumbar puncture, total CSF volume in the neuroaxis, 150 mLs. The rate of production is about 20 mLs per hour. A typical LP, we remove about 10 to 20 mLs of CSF. So typically within 30 to 60 minutes of time, the spinal fluid that we draw out during a lumbar puncture is replaced. Good numbers to just have in our minds. We saw this earlier. Again, hammering home the point, epidural space is an actual space present all the time. This is the basic setup for our diagram here. Again, dura mater outside, arachnoid mater internal to it, and then pia mater now covering the spinal cord and the nerve roots. And then the spaces we list out here as well. This is just a helpful coronal type view showing pia mater, and then external to it arachnoid mater, and external to that the dura mater. And then once again the spaces as we've already listed. Moving on to meningitis, a final topic here. So starting with bacterial meningitis, bacteria can form a few different things. First, acute purulent meningitis. Next, abscesses and empyemas can be caused by bacteria. And then chronic meningitis is another potential thing that can be produced. From a cell count, it's always going to be greater than 100. Of course, there's no absolutes in medicine, but it should always be greater than 100. Typically greater than 1,000. So you're going to see very high cell counts. Majority of them are going to be polys. Glucose is going to be low, and this can be one of the most important telltale signs of bacterial meningitis. Protein should be very elevated, and there should be high pressure as well. When it comes to viral, there can be acute aseptic, meaning there's an acute illness, but the person's not very sick. There can be an encephalitis, so they can be incredibly sick and confused and even comatose. And then there's arthropod-borne encephalitis as well. So from a viral standpoint, cell count's going to be elevated, but not quite as high as bacterial, typically. The majority will be lymphocytes, not polys. The glucose will be normal. Again, glucose can be an important indicator of what's going on. The protein will be elevated, and the pressure should be normal in viral meningitis. Granulomatous, meaning TB, plus fungal. So there can be chronic fungal meningitis, vasculitis is covered in this topic, and then parenchymal invasion, so granulomatous disease or abscesses. Again, the cell count's going to be elevated, but not quite as high as bacterial. The majority are going to be lymphocytes again. The big differentiator between viral and fungal is the glucose itself. The glucose will be low, just like it is in bacterial, and then the protein will be elevated and the pressure is going to be variable. There are other causes as well that we don't talk about here, but toxoplasmosis, cysticercosis, and then prion disease, CJD, if we want to think of that as a meningoencephalitis. Localization can be helpful in terms of helping identify what the etiology is. So here in the subdural space, we can have subdural empyema. We can have cerebral cortical abscesses, such as toxoplasmosis will do this. Leukoencephalopathies, such as from HIV, cytomegalovirus, PML, we're going to see in this white matter confluence of the brain here. Can form, and then basilar meningitis, so tuberculosis, cryptococcal meningitis, neurosyphilis, and then coccidioides, we're going to see in this basilar spaces, basilar cisterns surrounding the brainstem itself. And then within the brainstem, we can have what's called a rhombencephalitis, and listeria and viral encephalitis. Encephalitides can cause invasion of the brainstem itself. Finally, very importantly, HSV1, medial temporal lobe. So if the medial temporal lobes light up, think about herpes simplex encephalitis. Sometimes this can be one of the key and only findings of HSV encephalitis is medial temporal lobe involvement. So that's a primer on the meninges and CSF. A lot of really key clinical information in there. We talked about locations and patterns of hemorrhages. We talked about herniation patterns and their clinical findings. And then we talked about key findings in meningitis and how to distinguish the various forms of meningitis.